class. So today I'm going to discuss how to do a chest assessment for the respiratory system. So basically, in every typical assessment, you need to do first is you need to introduce yourself. You need to establish rapport with the patient, and to let the patient know what you're doing. You explain it concisely, and don't forget to wear that beautiful smiles of yours, because it would let the patient open up and be more cooperative with the procedure, and also it will open up the communication between you and your patient. So, well, doing the procedure, don't forget that if you are doing a invasive procedure, always get a consent of them. First thing to do is we need to do the history of our patient. We need to ask them what's the reason for their seeking of medical advice, or what are their chief complaint. And after that, knowing the chief complaint, for example, they have complaint of fever or whatever, cough, and then we need to know their history. What was the previous happening. So what was the history of your patient before the symptoms occurs. So we need to know if your patient is smoking, if your patient has a history of medical diagnosis related to the problem. You need to know also what are the lifestyle of your patient, the past medication, or your patient is having allergies and whatsoever, and anything that is significantly associated, significant happenings in the past that could be associated in the present illness of your patient. Okay, next, after you do the history taking, you need to get the biographic data of your patient. So after you're getting the history taking and then the biographic data of your patient, you need to do a vital signs taking to give you a baseline data of the vital signs of your patient that would be compared later on or along the way while you're doing your assessment. Okay. Next, after that, we could proceed with your physical assessment. So we start with inspection. You just need to look into the superficial structure of patient, and then it will be proceed. It's either of the percussion, palpation, and auscultation. But take note, this is a chest, so you can do first the palpation, the percussion, and then succeeded by auscultation. But take note, if we are doing a abdominal assessment, we will do first auscultation before any type of physical assessment. Okay, so now let's start with our discussion, and let's go with our model. Okay, I introduce to you my very own ta-da-dang. Okay, we're doing our inspection, guys. We just need to look at the structure of our patient. No need to touch it. So we just we need to look at it and see if there is slight color changes of the skin, if there is obvious deformity, and we need also to look at the symmetry, the symmetry of the chest, the symmetry of the chest wall, the anterior and the lateral diameter. So normally the anterior diameter must be greater than the lateral diameter, because if your patient has the same anterior diameter and lateral diameter, so it means your patient is having a box chest. It is a classical sign that your patient is having an emphysema. Okay, that's it. And also, when you do a palpation, you need to palpate. So just palpate the structure, and for females, you don't need to palpate here, not unless you are doing also a breast examination done by the examiner. If just for the sake of assessing the the chest. So just do here, no, have palpate in this area, first here and here, palpate, and down here, palpate, palpate, and just palpating, and just ask your patient if there's tenderness, if there's painful sensation be felt in doing it, and take note if there is pain, no, do not palpate even more, because you might add injury to the patient. Also at the back, no, at the back of your patient, just do the same, no? Just palpate, 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 palpate. And then also to know the if the expansion of the lungs is normal for the right and the left lung, you just need to hold your patient just like this, and then let your patient inhale and exhale. Or you can, yeah, hold this and then feel the expansion of the right and left. Look at the expansion. You can also do this at the back. Your patient should holding just like this, and then hold your back of the patient just like this, and then let your patient inhale and exhale. And then while you're doing that one, you're holding your patient, look for the expansion, no? If is the expansion of the lungs of your patient are designed with the right and left. So if you have this expansion, so it means it is normal, no? But if you do have this expansion, just like that one, so it means only one side of the lungs is expanded. So maybe your patient is having a pneumothorax, or the one side of the lungs of your patient is not expanding well. And you could confirm that one by using your percussion technique and auscultation technique, and listening with the sounds of your patient, of the lung fields of your patient. Hi there. In order to assess the lungs of our patient effectively, we need to know first the external landmarks or the external anatomy of the chest. So you already know with your previous knowledge of anatomy that the right side of your lungs has three lobes. We have the superior lobe, we have the middle lobe, and then we have the lower lobe. Unlike with your left lung, it only has two lobes. We have the upper lobe and the lower lobe, or the superior lobe and inferior lobe. So landmarks is important in order for us to locate the underlying thoracic structure precisely. So first thing is we need to locate the suprasternal notch. So suprasternal notch is located just below, no, just here, just in between your clavicle. And when you touch something like there is a depression there, that's the suprasternal notch. Okay, I will mark my suprasternal notch here. So this is my suprasternal notch. Okay, so if you locate your suprasternal notch, you will slide your finger down there. Okay, suprasternal notch, slide here. Okay, slide down there. And if you've noticed that there's something that like a depression there, or something like this protruding, that is the angle of Louis. Okay, so I will mark my angle of Louis here. So this is my angle of Louis. That's it. That's the mark of my angle of Louis. So what is important to why we need to locate the angle of Louis? Angle of Louis is important because there are important structures underlying in this level. So we have this level is the level where your trachea bifurcates into right and the left bronchus, and it also the angle of Louis marks the level of the right atrium. So, and also the angle of Louis is the level of your second rib. So when I palpate in this area, so I can palpate my second rib. So this is my second rib. So just above it is the first intercostal space, and just below it, this is the second intercostal space. So we have second, so I will count it. We have here second, we have here third, fourth, fifth, sixth, seventh, eighth, ninth, and 10. Okay, so that's it. So next is we need to locate the fourth and the sixth rib. Why? Because we need to know the border of your right upper, the middle lobe, and the right lower lobe. So first is we need to mark the fourth rib. So we know that this is the second rib, so the level of second rib. So this is the second rib, my second rib. The second, this is third, and this is fourth. So this is my fourth rib. So I will mark my fourth rib here. This is my fourth rib. Okay. So next is after we locate mark the fourth rib, so we next mark the sixth rib. So this is my fourth, and this is my fifth, and this is my sixth rib. So basically this is the sixth rib here. Okay, so why we need to locate those? Because those rib, those are the boundary of your the fissures that separates the right upper lobe, the right middle lobe, and the right lower lobe. How could I know? So in order to know the boundary between the right upper lobe and the right middle lobe, you need just to draw a from the level of your fourth rib. You just draw here just a little bit, just like that, perpendicular going to your mid axilla. So now we can mark the border of the right upper lobe, and we have the right middle lobe. So while your sixth rib is the demarcation between this is the border of your right lower lobe. So you need just to draw a line here, draw it, and go there and to the side. So now we can assess the three lobes of the right lung. So we have the right upper lobe. So most likely this is the larger area of the right lobe, right upper lobe. We have the right middle lobe, and a little bit lining of your right lower lobe. But when we look at this side in the axilla, by the way, the border of your the major fissure of the right lung is located in this. You can locate this one. This is the border of your axilla. When you let your patient raise their hands, you could assess that. Let me turn around. So you could assess that this area, the lower this border, no, the scapular border is the demarcation of the major fissure of the lungs. So if you draw a line here, so let me draw a line here. Wait. So if you draw a line here and connects it into the line of your sixth rib, so that is the demarcation of your major fissures of the lung. So by the way, when you look at the back, it only has the right upper lobe and the right lower lobe. So here at the back, we cannot assess the right middle lobe, because we can just assess the right middle lobe when we can only assess it in this area here when you let our patient in the axilla. So this is it. So this is the most likely this is the right upper lobe, this is the middle lobe, and this is the lower lobe. So this is the only area when we can assess easily the three lobes of the right lung. So we have the right upper lobe, right lower lobe, and the right middle lobe, and the right lower lobe. So now here you could appreciate that these are the landmarks of your right upper lobe. How could we know the boundary of the major fissure of your right lung? So that divides the upper and the lower lobe of your lung. So we need we need to know where is the fifth intercostal space in order to know the fissures that divides the upper and the lower lung. So we have here the angle of Louis. So I will count here from, this is the first second rib, the second rib here, the third rib here, the fourth rib here, this is the fourth rib. So we have the fifth rib here, and this is the fifth intercostal space just here. So if there's this is the fifth intercostal space, we just need to draw a line here. That's it, and go there, and yeah, look at here. And just what I did with the right side of the lung, so I just draw it from the lower border of the scapula. So from the scapula here, look at it, and oh wait, so that's it. From the scapular blade here, need to form a line, and yeah, that's it. So here we can assess, this is the right upper left upper lung and left lower lungs. And then when you see at the it at the front of your patient, so most of our assessment in the left upper chest is the left upper lobe of the lungs, but we have only a little bit of the left lower lobe of the lungs. Okay, so next thing is we need to know where to do a correct auscultation. Okay, so let me get my stethoscope. So when you're auscultating with the lungs, important principle is that you need to move from one side of the chest to the other side of the chest in order to compare the right and the left lung fields. So if you are going to start here, you will, the next area is we going to here, but first is we need to know, or we need to listen with the sound in the apex of the lungs. Remember, your lungs is in just like a it's just like a pyramid. So this is the base of the lungs here, this area, this is these are the base, the right base, the left base, and then we have the apex here. So basically your lungs is getting steeper and steeper here. So in order to listen with the apex of the lungs, you need to put your stethoscope here and listen. So as your patient breathe, inhale, exhale, so you will listen. So I will attach first my, okay, and then you put here the diaphragm of, you just use the diaphragm of your the stethoscope, and you put here, you let your patient breathe, and normally we can hear the breath sound here in the apex. So this is important because we want to know if there is consolidation, there is fluid that is accumulated in the apex of our patient. Next is we need to assess the upper lobes of our lungs. So first is we need to go with the right side of the lungs. So just tap in between the, make sure that the area you are listening is it's in between the, so inhale, exhale, let your patient inhale, exhale, and listen. And then next going to the left, then down to this side here. So basically we are done listening with the right upper lobe, then immediately we need to loosen the right lower lobe here, and immediately we go to uh, the the contralateral side, which is here. This is the right lower lobe, and then we need also to loosen the middle. This is the right middle lobe. For me, it's okay. And then if you want to listen with the it, you can also just put it in here, the middle. We have the upper lungs and we have the lower lungs here. As for me, it's okay. So clear breath sounds. And at the back, uh, it is important that you follow a zigzag, no, the side to side. So from the upper side of the back, you listen it, and then you move it into the opposite side and go down, opposite side, go down, opposite side, go down, and then you will fully hear the lung fills at the back. So basically, that's the basic way to do auscultation of the lungs. Next thing we want to learn is how to do percussion of the lungs. So by the way, percussion, this is a technique in order to know if there is a fluid content or there's a consolidation of the lungs, because as you do this one, it will create a sound, and the sound is different in the areas of the lungs that has consolidations or that has a fluid in it. So important thing to know before we start before we start our percussion is we need to know what are the area that is usually been heard as dull. So first thing is, it is obvious that in the left side of our chest, we can hear this in this area what we call the superficial cardiac dullness. So when you tap here, you know, so by the way, when we doing a percussion, it is found out with the long clinical testing and approaches that it's best that we just use our hands as the plexor, and in order to locate the area, stabilize it, and to locate the intercostal spaces. So when you're tapping the chest, you need to put your plexor in the intercostal space, okay? So in order to create an effective tapping. So as you can see, I am using my hands as the hammer, and make sure that your fingernails are short to prevent injury in your hands. As I'm doing this one, you could hear a dullness sound here as compared with this area. Okay, dull, because this area we can tap this is what we call the superficial cardiac dullness. So it is normal that in this area we can hear a dullness because we can locate in this area. We need also to locate where your liver be located, because if we are going to tap this area, we could also hear a dullness because this area here is your liver. So how could we locate the liver? So your liver can be located first in the we need to locate first the fifth rib. So this is my angle of Louis. This is automatically my second rib, second, third, fourth rib, and this is fourth rib, and this is my fifth rib here. So this is basically my fifth rib. So this is the demarcation of my fifth rib. So this is the superior border of your liver. And next, we need to locate the seventh rib. So this is the sixth, this is the fifth, this is the sixth, and this is the seventh here. This is the seventh rib here. Okay, So this is the 7th rib here, and to the back you need to locate the 9th rib. So basically the 9th rib is located here, so I need to put line here. So this is the 9th rib, and I will connect it to the 5th and here, here and here. So I need to use another pen, so that's it, so you could appreciate it. Okay, the green one is the border of your lever. So basically this area here, and here, you could appreciate the lever. So if you were going to tap here, it is normal to have a dullness sound here because this area is your lever. So as you can see, the green one, no, from the 5th rib and then the 7th rib here, this is the border, no? You can see this is the border of your lever. So it is normal to have here. And one thing, we need also to know that there is what we call trap space. So trap space is located, no, in the bubble of our stomach here. When we do tapping here, it is normal to have a tympani sound, a drum-like sound, because of the presence of the stomach here. So how could we know the throb space here? So the throb space is located in, first we need to locate the 6th rib here. So basically angle of Louis, second, this is the 2nd rib, this is the 3rd rib, this is the 4th rib, this is the 5th rib, and 5th rib here, this is the 6th rib. Okay, so when you reach the 6th rib, so you need to mark a perpendicular line here. That is it. And you can see this is the, where is my, you don't appreciate it. So this area I have here my border here of my rib border. This is my rib border here. That's it. So you can see it. This is my rib border, and then this is the 6th rib, and then next we need to locate the 9th rib. So we have the 6th rib here, 6, 7, 8, and 9. So basically this is the 9th rib. This is here the 9th rib. So we just need to locate this one, and this one we have to line this here. So this area, this is what we call the throb space. So it is normal when you tap here, we can hear a drum-like sound or tympanic sound. It's because of the presence of the abdominal bubble. But if you could notice that this area, no, when you do the percussion and then you cannot appreciate the tympanic sound or drum-like sound. So maybe the reason of that one is your lungs is overinflated. What is good thing to have this one, because even though your lungs, no, if you tap this one, if there is a consolidation, there is a fluid in it, so it remains the same, no, it remains having a drum-like sound. Even though if there is area is having a dullness because of the consolidation, you could appreciate that this would still be this having the same sound, except if there is an overinflation of lungs that would makes this area change its sound. Okay, so that's it. If we want to assess or to know the right upper lung, so we need to percuss in here in the this one, intercostal spaces. So tab here, you can see, and can go down, and then go down here and here, and then we could also tap here in the side. Okay, normally it's need to have a little bit of tympani but not dull sound, because dull sound would would indicate a consolidation or indicate that this fluid is accumulating in certain part of our lungs. But in this side, if we want to know the level of this area here, the second level, so normally it is just like a tympanic sound, or else it means that your aorta is enlarged if you could not hear in tympanic area here. So normally this area is dull because of your presence of your heart here. So don't assume this area would have consolidation, because you would hear a dullness of sound. But no, you're just percussing the superficial cardiac dullness. And if we're going down here, it should be slightly tympanic but not dull. Okay, and we're going down here, it should be high tympani, so it means should sound like a drum. So that's it. That's the way to do percussion and auscultation of your chest. And okay, I know you would ask how would we do the assessment of female. So you do the same process, but make sure that you provide privacy, and you need to just expose the area you want to assess. So basically, you want to drape your patient into obliquely, drape your patient on one side if your patient is female. But for male, it's okay to undress it, remove the t-shirt and just assess. And also, even though you're doing that one, you need to still provide privacy